Hello, everyone. Welcome. This is session IC71, titled Virtual Visits for Seating and Mobility Assessments. I am Julie, and I will be moderating today's session, and I will provide the CEU code at the end of the session. Before we get started, please make sure you mute yourself, and questions can be asked using the chat feature, which we will monitor throughout the session. I will go ahead now and turn it over to Linda Norton, who is our speaker for this session.
Thank you, Julie. I'm excited to have the opportunity to conduct this workshop with you, and I'm hoping that we can have some really good discussion through the chat. So get your fingers ready to ask questions or provide your perspective. So let me introduce myself first. I'm an occupational therapist, and I've worked in a seating clinic for many, many years before joining a provider of complex rehab technology. I am the Director of Learning and Clinical Education for Motion, and my scope is national in Canada. So although I'm based out of Ontario, I do education and workshops across Canada. In terms of disclosures, I do work for a complex rehab technology provider. However, I haven't received any compensation directly related to this presentation. So with that, I will move into the actual presentation and workshop itself. But I want to start with a context. Whenever I talk about virtual visits or I hear conversation about virtual visits, there seems to be a very strong divide. There's those that have embraced virtual visits as a way of conducting services or a way of participating in client evaluations, and there's those who are completely against it. And sometimes I feel that there's sort of a lack of conversation, that people get dug into one position or another. What I think has been really great about the conference so far is we've had an opportunity to delve into some of the research and hear people's experience around virtual visits and what's working well for them and how they have shifted during the pandemic. What this workshop really is about is thinking about what are your biases around virtual visits and maybe starting to think about them a little bit differently and starting to appraise what we do and maybe what we do into the future. So I don't need to tell anybody that our practice has sustained a massive change over the last couple of years due to COVID. And certainly, even during COVID, the mobility needs of our clients haven't changed. But depending on your healthcare system, depending on what happened in your region at a particular time, the way the client's needs were met or not met may be different. I actually had the opportunity to pull some statistics from a report from one of the agencies in Ontario looking at how service was impacted during COVID. And I don't think this comes as any surprise to you looking at this chart, that in terms of all of the respondents to the survey, many of them avoided healthcare services or had delayed healthcare services. But what was also interesting is looking at the effect. So in terms of people who had a delay in healthcare, they found that their condition was a lot worse or a little worse. So certainly we have some data that COVID had an impact. Not that I'm telling you anything new, but it's really the context that we need to start looking at. How do we provide service? What did we learn during the pandemic? And what does that mean for the future of service delivery in our industry? So in terms of objectives for this session, we're going to compare two different approaches to conducting virtual visits. We'll identify at least three components of the seating and mobility assessment that could be conducted virtually, and then also recognize at least two benefits of implementing virtual visits into your seating and mobility practice. One of the things that really strikes me is when there's a big event, it's an opportunity for change. And we certainly have all changed, and I think we've gotten tired of the word pivot in our language. But I keep coming back to this quote by Charles Darwin. It's not the strongest of the species that survive, nor the most intelligent, but the ones most responsive to change. And there's a great opportunity here to embrace change and think about how do we deliver service? How do we change what we're doing to be more effective and more efficient? So here's your first opportunity for comments. I'm going to have the chat box open as I am working through the slide deck and really want to have a dialogue and be able to converse with you. So what I'd like you to do is take a moment and start to think about, have you tried doing virtual visits or not? And if not, why not? What are the things that are your barriers? If you have done virtual visits, I'd like you to think about, so what's been critical to your success of doing a virtual visit? What are the things that you've been able to set up for your client or yourself that has really made it a successful experience? And then what are the barriers or hesitations that you have about doing virtual visits for seating and mobility? There's no wrong answers, but I'd love to hear you through the chat box. Just share what your experience is, and then we can use that as we start to move along within the presentation. So I'm just going to give you a minute right now to enter your thoughts into the chat box. There we go. Carly, you have win the prize for having the first chat in the chat box. Not that there's prizes that I can give out at the moment, but I thank you for starting the ball rolling. So let's see what people are saying in terms of their experience so far. So in terms of what's critical to success, a good iPad stand or extra person to help you get a good view from multiple angles. Absolutely. If you can't see what's going on, it makes it hard. Certainly the reverse of that is if there's a lack of technology, that becomes a problem. There's a comment here that I work at the VA and the platform works well as long as the client has the technology in place at their home. I also have a comment here that we have remained mainly in person. I also do not know how to bill for it. And that's certainly a concern that's come up in multiple agencies. In Canada, we have a provincial health system. So every province in Canada has a different approach to billing. And of course, has taken a different approach to how we bill for virtual assessments and virtual visits. Video was helpful for the doctor to see me and for me to see him, made it more comfortable. We do about 50% of our basic mobility appointments virtually. Figuring out how to get our clients scheduled and make sure they are able to get connected has been just as critical. For this, we do not cancel the appointment if the patient is not in the virtual room. We call them on the phone and help them get connected. And that's a really great approach. Certainly, the technology has created challenges for everybody. One of the barriers is not being able to feel what works in terms of force and area to support that position. And one of the conversations I was having last night in the NARTS room is that therapists and a lot of providers have smart hands. And what I mean by that is we get a lot of our information, not just through our eyes and through observing what's going on or asking questions, but really through feeling and touching and experiencing that client's position. So it's a really good point about that idea of having that hands-on feel. We have a comment here, been out of wheelchairs for 6 years, just trying to learn what it is to being done virtually now, what is working, not working, and what is allowed to be done virtually in the US. The one that I found most interesting was consumer trust in me. And that's certainly a really interesting point, Jerry, around being able to trust the provider and having that relationship and working back and forth that way. I'm just going to read a couple more comments and then I will start the presentation, but I'll come back to the chat box to see what other things have been added. There's a comment here that I've had good experience with virtual visits in my large rural state. I find it is dependent upon the tech comfort level of people at both ends, and that's absolutely true. One of the interesting things about virtual visits is it tends to potentially decrease the barriers imposed by geography. So for those of us trying to cover large areas, virtual visits may be a way to help to provide a better service to the client. I'm excited to see such positive response to virtual visits. one of the reasons that I started talking about virtual visits in this manner was not only COVID, but also a comment that I read in one of the studies and papers. And one of the things that I read was preliminary research suggests telehealth wheelchair assessment may be as effective as in-person assessment, is viewed favorably by wheelchair users and non-specialist assessors, while expert assessors have some hesitations. And I found this a really interesting comment in that even though it may be effective, even though there may be great things going on, as a person who is involved in the field or as an expert assessor, I may have hesitations about it, but that doesn't necessarily mean it's a bad thing. And this is where I come back to that idea of change. There's not a lot of people, as much as we talk about it, that truly embrace change all the time. Change can be really difficult for folks. And I think this is a really valuable quote to recognize that it may be our own individual hesitation with change that's creating a barrier to being able to look at virtual visits. So let's look at what we're being asked to do when it comes to preventing the spread of COVID and where we need to be. These happen to be in my province in terms of some of the directions we were given, but listening to the conversation over the past day, it sounds like the direction people were given was the same, regardless of where you were. So really, we were to limit the number of in-person visits for the safety of healthcare providers and patients. We were asked to conduct initial consultations over the phone, video, or secure messaging to do an assessment of whether or not a virtual assessment would be helpful, and that anything that could be safely and effectively provided remotely should be. Now, there's a bit of a switch of thinking there. It's not that everything is in person unless you prove it can be virtual. The direction we were given was everything is virtual unless there's a reason why it can't be. And it's an important distinction because it helps to shift our thinking in a different way. It helps us to start to consider, okay, what is absolutely necessary for me to be there in person to do? And what are the things that I can find creative ways of doing in a different way that doesn't require an in-person contact with that patient? So really, the summary piece of that is decreasing the number of contacts and decreasing the length of those contacts. Part of what we were asked to do as well is a risk assessment. And the College of Occupational Therapists, which is the regulatory body in Ontario, was providing the direction that we needed to remain vigilant and continue to conduct point-of-care risk assessments to determine what appropriate personal protective equipment and infection prevention and control processes are required to ensure client safety in their practice. So it's interesting. They talked about personal protective equipment. They talked about other safety practices. But one of the things that I would challenge you to do is you're starting to think about how are we keeping our clients safe and how are we implementing these types of regulations, is to start to raise your own awareness. And in your client file, one of the things you might want to keep track of is how many in-person hours per prescription are you doing? And recognize that if there's a 1-hour visit attended by multiple people, each person there counts as an hour of contact time. So for example, if there was a 1-hour visit that was attended by the OT, that should say ATP technician or caregiver, that would be 4 hours, right? And then the question is, how do we reduce the number of those in-person hours for that individual client? What I found helpful when I started thinking about risk and thinking about how do we provide a lower risk environment for our clients is really taking a public health approach. And if you read the public health literature, there's a hierarchy of controls that can be implemented. The best one is to eliminate and remove the hazard altogether. Well, the reality is that's not going to happen when it comes to things like COVID. We could replace the hazard. This is something where, if you think about the workplace, maybe reducing a more harmful chemical with a less harmful chemical. Again, not something that we can do for COVID. Engineering controls are something that I'm sure we're all familiar with in relationship to infection. So that's around social distancing, that's around limiting the number of in-person visits. Then you have that administrative control, and that may be, again, related to, are there things that I can do virtually? Are there things that, I can get somebody else to do or use technology? And the last one is that personal protective equipment. One of the comments that I got from therapists as I started to explore virtual visits is that I don't need to do virtual because I've got PPE now. And the reality is having personal protective equipment is important, but it's not the sole way of protecting the client or protecting ourselves in these sorts of situations. So let's think about what some of the processes could be to try and conduct a virtual visit, and what are some of the models? Well, the two models that really came up as I was reviewing the literature when we talk about virtual is that one was the clinician was remote, the expert clinician was remote, and there was a novice clinician with the client. So sort of a hub and spoke type idea where the hands of the expert clinician were still knowledgeable clinical hands, but not necessarily knowledgeable in the field of seating and mobility. The other approach was to be having the expert remote and not having a novice clinician with the client. So the client might be on their own, or they might very well have a caregiver there that's not familiar with seating and mobility. So what are the comments? And this is not an exhaustive literature review. And we've certainly had more literature presented to us over the last couple of days. But there's a couple of things to start to think about. Is when you have an expert clinician working with a novice clinician who's remote, there is some interrelated reliability when it comes to functioning every day in a wheelchair capacity. So what that means is just because you're remote doesn't mean you're losing the experience of observation of that client. And there may, in fact, be things that you can observe that you haven't observed normally when the client comes into a clinic setting. And we certainly learned that from the session earlier today around the environment that you may see behind the client is different than what you imagine it to be. What's also interesting is from a patient satisfaction perspective is that clients seen by telerehabilitation had similar client satisfaction ratings as well as seating outcomes to those being seen face-to-face. So for the clinicians who have the reaction, nope, this can't be done virtually because it's not good for the client, evidence would suggest that that's not necessarily true. It's not an all or nothing position. Similarly, if we look at situations where the expert is remote and there's not a clinician with that client, there was a situation, it was a case series that was done where they were looking at transfers for clients who were remote. And what was interesting in that situation is the therapist commented that she was satisfied with her ability to evaluate the client's seating position and weight shifting, despite that initial reluctance to using telerehabilitation rather than seeing the client in person. So this goes back to that attitude piece or that concern piece where we're not sure that we can do it. There's a hesitation amongst the clinician, and that may be a barrier to proceeding. What was also interesting was the quote from the study that said, televideo can provide information similar to that of traditional on-site assessment, as well as permit therapeutic interventions to be delivered without requiring a therapist to be physically in a client's home. So those are the two different models, right? First model is expert remote, clinician with the client, or expert remote, no clinician with the client. There is some literature pointing to a third model that I think is also worthwhile exploring. And the issue with that is looking at having a screening assessment or consultant review, and then having what they call a TCT, which is a telehealth clinical technician. So somebody who actually brings the technology to the client and assists with that technology, as well as potentially assisting with the assessment. So consider, for example, for a client, it may help to reduce the amount of time the client spends traveling. It may also help to reduce costs of having therapists involved in terms of they're not spending time driving back and forth, they're spending their time clinically with that client. It may help in terms of getting some provider buy-in in terms of here's a way of working together. May create really strong team members, because if you're thinking about working in this type of environment, it's almost bringing some of that transdisciplinary team perspective into the idea of working together. So maybe there's some cross-training that happens amongst roles to be able to make this type of situation work. In our model in Canada, we usually have the vendor or the ATP. We have a clinician and we may have a technician involved. Potentially, there's a way of reducing the number of people who are with that client by having whoever is hands-on with that client be responsible for operating the technology for the virtual visits, and then having the other team members remote. So you still have somebody hands-on with the client, but the question is, whose hands need to be there? And I think that question of who needs to be hands-on with the client is really a way to explore how we can move forward with virtual visits into the future. So I want to ground the conversation thinking about the ResNet Service Provision Guide and the different steps that are there. So that referral, assessment, equipment recommendation and selection, funding and procurement, product preparation, fitting, training, delivery, follow-up, maintenance, and repair. So how can we start to think about that model and then think about who needs to be hands-on with the client? Now, recognize we all have different skills, right? There's technicians who can make the chairs do wonderful things. There's therapists who have the skill in being able to assess position, feel tone, all of those various things. But we don't necessarily need every pair of hands in person all of the time. And maybe that's the key to reducing the in-person visits, is thinking about working in this type of hybrid model. So let me pause there and see if there's any comments specifically around that idea of whose hands need to be there. I do see comments around preparation and structure for the visit is often vital for success, and I would totally agree with you. And that pre-planning idea is incredibly important, so that when you come to that visit, or when whether it's virtual or in person, it can be as efficient and effective as possible, so that you are being very targeted in the way that you approach things. So let me think about now how moving forward with this. Well, there are certainly aspects of this process that already happen remotely. So often the referral happens remotely, and checking in to see whether or not that client is appropriate for referral often already happens remotely. It happens through people calling, it happens through email potentially, and there is an opportunity to start to think about, so how could we also screen for availability of technology or ability to participate in a virtual visit? One of the comments that I heard from clinicians that I was speaking to is they really appreciate the opportunity to talk to the client on the phone without seeing the client in person, without seeing their environment, because it allows them to listen to what the client is saying without necessarily filtering it through what they're seeing. So what the background of the client looks like, what their environment looks like, they can truly hear what the concerns are of the client before they proceed with a virtual visit or an in-person visit that takes into consideration more of those visual components. The second thing to think about is funding and procurement. Often the funding paperwork happens externally or not with the client present, and procurement of that device. So the ordering from the manufacturer, those sorts of things also happen virtually. And then that product preparation, if there's really good measurements on that client, if there's really good data, then it may be possible to set up that equipment for that person and get it ready to go, again, without seeing that client initially to get that started. I see there's a couple of comments about what I've been saying. We have done this depending on the circumstances and knowledge of the ATP and clinician. We do it based on client needs. And absolutely, it's really around thinking about that client's needs and who needs to be there. There's a question saying, are many suppliers doing virtual visits before eval with the clinician, such as home assessment, assess the current equipment, CRT equipment, et cetera, to prepare for the evaluation? And in some cases, that's true. In some cases, the vendor has already been out, seen the client, had a initial visit with that client to gain that information. Or they may already be familiar with that client and their surroundings from repairs that have already occurred in the home. So often that collaboration and that ability to check out who knows what information and have that permission to speak as a team can often help to condense some of this process with information you already know. So let's talk about the assessment piece. And as we start to think about assessment, we need to break it down and think again about how do we decrease the number of contacts and how do we decrease the length of that contact. As we start to think about that, recognize that this is all going to depend on the level of complexity and the level of equipment and type of the equipment that the client might need. Is this a new or returning client? Is it somebody we already know? And is it new or replacement equipment? Often we start to engage in these conversations, folks tend to think about the extremes. Well, I can never do that with this kind of client. Well, sure, perhaps they're too complex that you need to be in place for. But let's go back to the original perspective that we were given. The original perspective we were given and the way we needed to think about practice is that everything is virtual unless there's a reason to be in person. So let's think about how do we do this virtually and figure out what the exceptions are to that. So let's look at the domain of assessments. First area is body structure and function. So that includes things like diagnosis and prognosis, neuromuscular system, a range of motion and skeletal alignment. It includes skin integrity. It includes current mobility skills that the client may have and the need to accommodate other strategies or devices for that client. So the first question to ask comes, as we were saying, what information has already been collected about that person? What do we already know, or who knows that? Then the second question is, so what are the tools that may help us in a virtual world? And one of the tools that I really wanted to bring to your attention was the photographic wound assessment tool, or the PWAT. I've given you the link to the tool there. And it also has the instructions for the tool. In wound care, expert clinicians have been doing consults on patients just through photos of wounds. And so it can be a very effective way of communicating what's happening with that wound that you may not necessarily need to see it in person, and may give you another way to gain that information. Also, it's a great opportunity to connect with the clinician that is there. Certainly, Julie, I agree with you. It's difficult when a non-clinical staff is doing the triaging for the appointment, for sure. It may be a tool that's used by the clinician when they're involved, or at least asking to see if there is art, if there is photos available, maybe the preparation that we do ahead of time. The next question is, can any information be collected virtually that would decrease the amount of hands-on time? So asking the client about their current mobility skills may be a way to start. Asking them about their diagnosis and prognosis probably is already happening and potentially could happen virtually. The need to accommodate other devices, we can at least ask about those accommodations before we go into that assessment. Where the hands-on care really is needed, particularly for clients with complex needs, is around that range of motion skeletal assessment component and around that neuromuscular system. However, if you've done a really good job in the first visit collecting all of the information that you can around that client, what their needs are, then that part of the assessment where you're assessing the range of motion, the alignment, and the skin integrity, the neuromuscular system, the range of motion, and skeletal alignment can really be done efficiently, effectively, because that's the piece you're going in to see. Everything else you've collected and you've built that relationship with the client virtually. So that's one way to consider doing it. And when it comes to whose hands need to be there for that part of the assessment, it's probably the clinician's hands. It's probably the person who understands those systems and is the one working on the prescription in that piece. It may not be everybody's hands. So in my system, for example, if I've got the therapist, the vendor, and the person who adjusts the wheelchair, the service technician there, it would be my hands that would be the most appropriate in that circumstance, or the clinical hands. Let's look at the next piece. Let's consider looking at the environment and current technology. So that includes the devices used, what environments that client goes into, and then all of the support systems that are around that client. Again, we've got that same question: has this information been collected by other team members? So often in my system, vendors have a really good history of all of the equipment that that client has. So that might be one way to approach it. Asking the client what devices they have is incredibly important. And one of the questions I like to ask is, what are the devices that you have that you're not using? Because that's when all of the cushions and things that they have come out of the closet. And sometimes when the client is in their home and doing something virtually with you, they may feel more at ease to answer that question, or they may sort of look around their environment, and that might stimulate a response that they may have forgotten to tell you when they were in clinic. When we think about environment, one of the advantages of doing a virtual assessment is you can see their environment if you're not authorized to do home visits through your clinic. But part of the thing is we're often doing the environmental assessment remotely anyway. So we don't necessarily travel into all of the areas where that client uses that device. We're often dependent on them reporting anyway, well, what happens when you go to your daughter's house, or what happens when you go to work, or what happens when you go to the camper or the trailer or wherever it is that they're going, and sussing out the accessibility needs that way. Same thing with the support system. Often we're getting that from conversations that we're having with the other parties involved. Often it is through observation of the client and their environment, and that may be one way to get through. One of the interesting things about virtual visits, though, is there may be an opportunity with the client's permission to get other people involved into the assessment who wouldn't normally be involved. So a good example of this perhaps is, a family member or a daughter who lives in a different city or a different area. They can attend virtually and be part of the assessment and have their questions or concerns answered as well. I'm going to pause there for a minute because I see there's a comment here, and it says, you mentioned accessibility assessment for the home. Is there a movement to make resources needed for virtual visits fundable by insurance, i.e. internet access, hotspots, video conferencing devices for clients who don't have these resources? Also thinking beyond the initial assessment to maintenance and repair, programming, et cetera. I think it's a really good question. Certainly different regions are doing different things. One of the documents that might be worthwhile going back to is the World Health Organization and their Convention on Persons with Disabilities. There's certainly information in there about what technology people need to have access to in order to be able to participate in life. But I can't recall offhand if there's something there around access to technology in terms of internet and those sorts of things to be able to participate in life. Why I'm directing you there is I know Canada and perhaps the US have signed on to these conventions, and it gives us another way to leverage the providers, leverage the funders to start to think about, if we've signed on to these conventions, how are we actually expressing that in day-to-day life? To learn more, the work I would refer you to is Rosalie Wang, and she has a website called Access AT Now, I believe it is. And in there, it has all of the Canadian funding sources for assistive technology, but it also has a list of resources in her research around access. So this might be one of the things that she delves a little bit into. I can't remember offhand, but I would certainly direct you to her research as well. I do think it is something we need to advocate for, and I think it's something that's not going away for sure. We then need to think about activity and participation. So for our clients, what is their current and desired level of ADLs and IADLs? A lot of this you can observe remotely and watch them do things. What's exciting about that is they're doing it in their own environment. So it's already set up for the way that they typically do that, rather than trying to describe it to you. So they can show you the devices they use, they can show you the setup that they use, and that may be helpful in terms of triggering what's possible for them. Same thing comes with movement pattern or technique to control the mobility device. A lot of that you may be able to observe through a virtual visit, being able to see what they do. One of the things that it comes down to often when it's around movement pattern to control is really getting a sense of what is that person's strength when they do that, what is that person's ability. And you may need to have a pair of skilled hands on board to be able to assess those sorts of pieces. Again, that comes down to the level of complexity. If it's something where the client is able to use a joystick, they are demonstrating that through using the joystick for other things, or the way they're interacting with the technology, then that might not need a same kind of hands-on in-person assessment initially. That may be something that comes with the programming of the joystick when you're actually delivering the device. So it might not necessarily need to occur now. So let's think about equipment recommendation and selection. And this is really where, based on the assessment parameters, you're really starting to look at what equipment might be most helpful for that individual client. And this is, again, an area where virtual technology may be really helpful. You may be able to share your screen and share resources with the client. You may be able to show them videos of how things work. And one of the advantages of that is at least you know that you and the client are looking at the same thing. So it's not a situation where the client is trying to say, well, I saw something on the internet that might be really great. This gives you an opportunity to make sure you're in the same conversation, looking at the same piece of equipment. And it's potentially an opportunity to go through the order form with them and start to show them and discuss with them what the options are. Sometimes in clinic, I find we're trying to describe to clients, what's available, but unless they can see a picture of it, it's hard for them to make a decision. So this may be one way that our virtual visits may be an advantage rather than a disadvantage. If we are doing equipment recommendation in the home, or we're doing a trial of something in the home, the question is, what pair of hands do we need there? And this is a circumstance where perhaps it's the technician's hands that need to be with the client in terms of setting up that equipment, working on programming, working on adjusting the equipment for them so that they can have a successful trial. And then at that point, having the therapist remote watching that. And we certainly have examples of that we've used at Motion, where we've had the technician go set up the equipment, and the therapist has been remote observing that setup, observing how the client moves, and asking questions. How much space is behind the client's knees, for example. So really being able to direct those hands. That's really where that opportunity for transdisciplinary care comes. Traditionally, when I've heard about transdisciplinary care, it's been between an OT and a physio. But maybe transdisciplinary care in this context is between the clinician, the assistive technology provider, and perhaps the setup technician or whoever you have. And that maybe there's an opportunity to train different people to do different things. So for example, as a therapist, when I was working in that role, it was very unusual for me to have a set of tools with me. However, it makes a lot of sense in that if I can do an adjustment and not have to have a technician out or the vendor, and we work in conjunction, then maybe that's a way to train my hands for at least for some of the simple adjustments. We need to think about fitting, training, and delivery. And I think this fits in well with that idea of equipment recommendation and selection. In that, if we've had that opportunity to deliver the equipment and we have a technician who is there being able to set up the equipment, then maybe that's not where the therapist needs to be. Maybe the therapist is remote. And in that way, try to have less people there, but still have the different perspectives and the expertise. I have a comment I see in the chat box here that says, very often here, the ATP in the home can demonstrate the equipment as would be used in the most common environment. A collaborative environment between the therapist and the ATP is best here. I totally agree. One of the pieces of that comes back to a comment that Jerry had in the chat box earlier about making sure there's that trust between the client and the ATP, but also the ATP and the clinician and the client. By creating that trust and that ability to work together, that's really the only time transdisciplinary care is successful, is when there's that trust. There's a comment here from Tamara saying, I love being able to do a little wrenching and improve the situation on the spot, even when I'm the only one there. I'm an OT. I absolutely agree with you, Tamara. I certainly have that urge too. And the only caution is making sure we're not biting off more than we can chew, and making sure that we have the training when it comes to certain adjustments to make sure that we're still creating safe equipment for that client. But it makes sense. If we're there and we have the ability to make that adjustment, it makes no sense to have another contact for that client just to do a simple adjustment. Comment from Julie here, ATP at home for delivery, therapist remote. This has worked really well for us. So I'm glad that you've got an example of that too, in terms of having that idea of the therapist working remotely and the technician with the client. It's also a great way to partner, right? So that maybe it's a way of allowing that client or that clinician to see more clients because they don't have that windshield time of driving between the clients, or the client having that time of trying to get in for service. Julie's saying, love how you're using the wheelchair service provision guide as the backdrop for this and how remote service delivery could work. Can you share your slides as a handout? And yes, I'd be happy to do that, Julie. I'm happy to do that. So I'm going to pause here. Actually, I'm going to do one more and talk about follow-up maintenance and repair. And certainly when it comes to follow-up, there are a lot of clinicians already doing this virtually prior to COVID. So there was a phone call that would happen, or there may actually have been a virtual visit happening to follow up with that client around how that equipment is working. Maintenance and repair is really interesting. And I'm not sure how every system works, but I can certainly express how our system works when it comes to funding and repair. So prior to COVID, the way that our funding would happen for repairs would be that the client would identify their need and would seek approval from their funding agency to have somebody come out and assess the chair for repairs. And oftentimes this step was challenging for the client and often challenging for the vendor, because the client would call us rather than calling their worker. Once we had approval to go and see the client, we would go out and see the client to figure out what needed to be repaired. Now, to be clear, we weren't allowed to repair the chair. We were only allowed to go out to find out what needed to be repaired, okay? Then we would need to complete a quote. That quote would be sent to the funder to review. And then at that point, an approval would be sent out to the vendor. We, at that point, as the vendor, would order parts. We could then schedule and go out and see the client. The client would sign the work order, and then we would invoice for payment. So there was a lot of back and forth and a lot of windshield time when it came to this type of process. As a result of COVID, one of the exciting things that has happened is a lot of the funders are allowing for a virtual visit, even for a service repair. And what that means is that there's an opportunity for the technician and the client to have either a telephone conversation or an online virtual conversation to diagnose and troubleshoot the issue with the chair. There's a couple of really great things that happen with this. First of all, the technician is really clear on what's happening with that chair and can submit a quote to the funder. But often the situation is something that can be resolved solely through that virtual conversation. And this particular funding agency is providing funding for that technician virtual visit. So that's a really exciting win. It makes it easier for the client, and it certainly makes it easier for the technicians involved so that they're really focused on doing the diagnostic and the resolution, and they're not spending so much time on the windshield time. And depending on where the client is and their region of service, there's times a technician could be driving for 4 hours to see a client, and it just turns out to be something simple that the client or caregiver could have fixed over the phone. So really an important development in terms of how this is happening. So I'm going to pause there and ask you a question. Are you feeling, or what sorts of things are getting you to shift your thinking about what's possible for a virtual visit? Is there anything that I've said that has surprised you or made you think differently about your practice or the practice of those with whom you work? You guys have been really great about using the chat box, so I'll leave that as an opportunity for you. Don't see any other comments, so I will continue to move on. There is some new and exciting research going on. One of the out west in Canada, there is some research happening that is right out of the Big Bang Theory. I'm not sure if there's any of you that are Big Bang Theory watchers or people who appreciate the show. But Sheldon, one of the main characters, had a Sheldon bot who would wander around and interact with people so he didn't have to. He could basically stay in his bedroom and live there. Well, this therapist is experimenting with using essentially a Sheldon bot, just like what you see here, as a way of participating remotely in seating and mobility assessments. So that's really exciting because it means that now they have the ability to move themselves around the environment. Now, this isn't an environment that's in a facility. And what she's finding is as she's maneuvering herself down the hallway is people are stopping to interact with her the same way they would if she was actually there in person. So it's really cool to see that the future is now. It really is an opportunity for us to think differently about how we interact with people. And potentially, if we're thinking about facilities in Ontario, for example, that were in lockdown, where residents had to stay in their room in long-term care, maybe this is a way that we could still complete a virtual visit and see the client and interact. So some really exciting opportunity. I have a comment here about that they appreciate my message about embracing change. And I think it's really true. We embrace new technology, we embrace new developments for our clients in terms of seating and mobility technology. Now we need to think about how do we embrace technology for our own service delivery model? How do we move outside of our comfort zone and start to explore some of these really cool ideas? Now, this Sheldon bot isn't millions and millions of dollars. We're talking, some of the pricing I saw was around $5,000 Canadian. So something that may be really approachable in terms of a way of participating in virtual visits. And then the question is, how do you get your robot there? That may be a whole other piece, but think about what the possibilities might be. It's very exciting to me. So let's think about some of the advantages and what's the benefits of virtual visits. Well, there's a number. First of all, in the current state that we're in, we have that decreased risk of exposure to COVID-19 due to decreased physical contact. And we are moving into a phase where we're learning to live with COVID, but that doesn't mean there's not going to be another disease or another reason or another opportunity for social distancing or clients who are at more risk that we need to protect. So I don't think virtual is going to go away. I think it's something that we need to embrace. I will say prior to 2019, there wasn't a lot of research really when it came to virtual visits and seating and mobility, but that's definitely changed when we start to think about how the pandemic has changed things and how we have rechanged models. There's certainly now much more research going on that I think we need to embrace. The second thing we need to think about as potentially an advantage is an increased efficiency of those in-person visits, so that they're very targeted and very focused. If it's on the assessment side, we've collected all of the information that we can virtually, and we're just going in for a short time to check those things that we can't do virtually, like assess tone, for example, or assess range of motion for somebody who has complex contractures. But it's also, again, a way of increasing the efficiency of in-person visits for service repairs, for example. So doing that virtual visit first, finding out and troubleshooting what the issue is, and even potentially repairing the chair virtually is really exciting. There's certainly some of our manufacturer partners who are looking at how can we connect with chairs virtually? Can we do a diagnostic? Is there things that we can do without ever seeing that client? And I think that's a really exciting time. Some of the other things that we're seeing, though, when you start to delve into the literature around virtual visits, is a decrease in waiting lists. And this decrease comes from that ability to potentially see more clients and do more of that virtual assessment, more of that time focused on clinical care, rather than driving between appointments or that type of thing. And then the last advantage I think we really need to embrace is that idea of using that transdisciplinary team and really building that expertise around us so that we're able to work in that environment. We know what we expect from each other. We have a shorthand of talking to each other. We know that, hey, I'm working with this rep. He's going to ask me this question, so I better get the information. Or I'm working with that therapist. I know that she always asks this question. Let me see if I can make sure I have the answer to that. So by creating those environments, that's how we can create and foster change. So there's a couple of comments here. I have a kiddo that attends school using her bot. What a cool application. Absolutely. Doesn't that sound like a fabulous way of doing things? And then we have a comment here from Joe. We also have the ability to share screens, guide patients through these systems. This includes completion of forms or explaining technical details very efficiently. Totally agree. One of the conversations we had in the NARTS room last night was in the NARTS Code of Ethics. There's a standard that we give the client the options and they can choose, right? We present them with all the possibilities. And by doing something virtually and sharing your screen, it makes it much easier to talk about those possibilities, to talk about what it is that the equipment or the options are, so clients can make informed choices. So it certainly is an incredibly important part. So I want to come back to that challenge, and this goes for everybody who's participating in this assessment, is I'd love for you to challenge yourself. So over the course of that prescription, just keep a running tally in your notes about how many individuals interacted with that client, how many times, and for how long. By making that visible, it starts to become part of your thought process. And it starts to become, so how do I decrease this number while still providing good care? Does everybody still actually have to be in the room? I see a couple comments and questions happening besides FaceTime, Zoom, etc. Is there a secure platform you would recommend for the use of virtual visits? And I see people have already answered. Our place uses Teams. We have Microsoft Teams. Our Epic system is connected with Amwell. We started using video, which did not work much at all. So one of the real keys to this is during the pandemic, a lot of institutions relaxed their requirements around privacy and security from an electronic transmission piece. As we move further down the road of technology and virtual visits, it's really important that we go back and revisit the privacy pieces and security pieces to make sure that we're meeting or exceeding the legislation in our areas. Certainly some of the OT organizations in Canada have provided a review, but certainly one of the not easy, but one of the best ways is to look at what the legislation says needs to be in place, and then do a review of each individual system with that. Certainly there are organizations who do that, and there's an organization in the States who's built a set of guidelines around virtual visits for healthcare, and that may also provide a useful resource as well. I see a comment from Julie here that our Epic system has a video platform, but they have to be active on the portal to use. So that makes sense. So let's review what we've talked about. We've compared two different approaches to conducting virtual visits. So that idea of having the expert remote and a novice clinician with the client, or having the expert remote and not having anybody with the clinician. And we actually talked about a third where you have a novice or an expert clinician interacting through a technology person. So perhaps the vendor who also brings the technology with them to make sure that virtual visit happens. We certainly have had success with that model where the therapist is remote and one of our reps takes the technology with them, and it basically facilitates the virtual visit with the client. So that tends to work really well. Identify at least 3 components of the seating and mobility assessment that could be conducted virtually. Well, we have identified lots, right? Some of them already occur. When we think about referral, we think of the securing the product, we think about funding applications, but there's also parts of the assessment like determining what equipment the client has previously, thinking about their diagnosis and prognosis, thinking about what other equipment that they have. All of those are components that could potentially move very easily virtually. And then the last piece in terms of recognizing 2 benefits of implementing virtual visits into their seating and mobility practice. Well, one of them is decreased wait list for the client. It may result in decreased windshield time for you, may also result in decreased travel time for the client, which is also really exciting. It may also help in terms of creating some of those efficiencies in that transdisciplinary team. And it may also help to improve safety of the client, particularly those who are really vulnerable and high risk for catching COVID in the state that we're in right now. Andrea, I see a comment that you've made. In Virginia, the therapist and the client both need to be in the state for telehealth to be eligible for reimbursement. And that's a really good point. Often with telehealth, we can collaborate with experts, and we're getting used to collaborating with experts that aren't necessarily in our same city, our same province, our same state, or even our same continent. And that's really, really exciting that we can start to draw on each other's expertise. But you're right, when it comes down to that individual client interaction, there's often rules and regulations about who can be involved and from what geographical location. So certainly you're not alone. I know in certain provinces here, the provider and the client have to be in the same province, and the provider, the clinician, has to be the license to practice in the province where the client is receiving service. So if the provider is in Ontario, The client also needs to be in Ontario because our licensing is provincial. There's certainly some of those issues as well. I'd like to leave the last few minutes to you to see if there's any questions that you may have. There is a list of references that I'll make available in the slide deck as well. And my contact information is also here. So certainly don't hesitate to reach out to me directly if you want to have a conversation about any of these things, or if you have any questions that I haven't answered. I certainly appreciate that you've shared your experience with me and shared your expertise, and that's really exciting to be able to have some of that dialogue and start to stimulate the conversation. There's a comment here from Joe that it may depend on the funding source. Medicare, for example, is often reimbursable. And that's the challenge, right? Everybody is dealing with a different funding source. So it's really important to be able to delve into what's actually fundable in your particular area, because it's going to differ and change depending on where you actually are. I see that the code has been posted, so I'll read that code out to you from an accessibility perspective. It's 2GATQW.
Thank you, Linda.
Oh, go ahead.
I just said thank you for reading it.
You're welcome. With that, I see we're at the end of our session. So certainly, as I said, please feel free to reach out to me if there's anything that I can do to be helpful for you.